we have recently in this space in terms of actual approved drugs that are available in the clinic. So we still have the backbone of surgery plus post-surgery chemotherapy. We had an approval a couple years ago for people who are EGFR positive, adding 3 years EGFR targeted therapy, and that improved time before cancer relapse. And then we have also for PD-L1 positive patients, that immune target, we have approvals for 1 year of adjuvant immunotherapy, the atezolizumab, which also improved the time before cancer relapse on average. We're talking today more about preoperative treatment, and this is the newest data we have, which is neoadjuvant chemotherapy plus immunotherapy. And this is the CheckMate 816 study data. So I'm actually going to take us through that data in some detail, and I'll show you the study design and some of the outcomes we're looking at, trying to show benefit to this sort of strategy. So what was this study? This was a randomized study for people with a new diagnosis of lung cancer that a surgeon felt was resectable. There's some official stage numbers there, stage 1B to 3A. Those refer to tumor size and the extent of lymph node involvement. People had to be healthy. And then they were randomized to get either just standard chemotherapy, which was 3 doses, 3 weeks apart, pre-surgery, or same regimen, standard chemotherapy plus an immunotherapy drug called nivolumab. And then those patients went to surgery and then could be treated after surgery, however their treating doctor felt was appropriate. They looked at what's called a primary endpoint, which is the primary measure of whether the treatment was working in the study design. In this case, it was the pathologic response rate, so the chance of not having living tumor on a microscope slide, and event-free survival, so risk time until tumor actually came back. They also looked at overall survival, of course, which is we consider to be our gold standard endpoint in any trial. Do people actually live longer overall, regardless of their cancer status? So these are some of the measures we look at. How do you measure success of preoperative treatment? These apply to most clinical trials in cancer as well. You often see the response rate reported, the ORR, and that's what fraction of tumors actually shrink on their imaging scans. You can look at the pathologic response rate. That's looking at, if you actually take that surgical sample when it's removed from the body, what fraction of tumors, pathologic complete response rate is what fraction of tumors had no living tumor cells left behind. You can look at event-free survival, so that's how people are living on average without tumor recurrence. And you can look at overall survival, which again is our gold standard. Our most strict endpoint for any study is, are you seeing improved overall survival? We consider that many times the very best endpoint that we're looking for. So in CheckMate 816, here's those survival curves for, this is event-free survival. So how long are people living on average without cancer relapse, or people who aren't having cancer relapse? And you can see it was improved by adding immunotherapy pre-surgery. And it went up from 20 months to 31 months, so almost a year by doing that. So it showed better survival post-op for these patients. You can also look, everyone worries with a neoadjuvant treatment, a preoperative treatment, you don't want patients not going on to surgery because of something related to the treatment. So studies will usually report how many people actually got the planned surgery, were there any delays, any issues with the surgery. So here you can say that patients who got the chemo plus immunotherapy were actually more likely to go on to surgery. 83% went on to surgery versus only 75% who got chemo alone. So it seemed on average, it was actually making you more likely to get to your surgical resection. You can also look at what did that surgery look like? And you can see here that by getting the immunotherapy with chemo, you were more likely to be able to have a minimally invasive surgery, as opposed to say more open surgery, which is tougher to recover from. And you were less likely to need to have a pneumonectomy, which is a full lung resection, again, a bigger surgery with more potential long-term effects on health and well-being. You can then look, what about that surgical sample? Was the tumor actually dying in the samples? That's that pathologic complete response rate. So what fraction, no living tumor cells visible? And that was a big improvement in orange there, adding immunotherapy. 24% of people, their tumor had no visible living cells versus only 2% if you got chemo alone. So more than a 10-fold improvement in the chance of seeing no living cells. We know also that it probably is a good thing, that if you have a pathologic complete response, that's that top curve, you were more likely to be cancer-free at 2 years, 93% than if you did not have a complete response, where only 58% of people were cancer-free at 2 years. So likely for future study design, if we're able to look at things like pathologic response rates, we can almost predict from that surgical sample how happy we are with that treatment. That may allow for future study designs that allow us to modify treatment based on how good of a response we've seen to that initial preoperative therapy. So who might benefit the most from this treatment strategy? This is called a subgroup analysis, and you'll see this figure in paper. So what this shows is the dotted line is equal benefit either way. And then if your dots are falling to that left side of the line, it means that you were benefiting more from getting immunotherapy. If you're falling to the right side of the line, it means you're benefiting more from getting chemotherapy alone. I'll highlight a few things here. One, people with more advanced disease, that's that top line there, the top arrow. Through stage 3 disease, there was more benefit to adding immunotherapy. It was a little more equivocal. You're closer to hitting that dotted line there if you had earlier stage disease, like stage 1 or stage 2. And that second arrow, you also had the most benefit if you had a high PD-L1 expression on your tumor cells. And that's that biomarker that the drug targets. So when it's high, we know immunotherapy tends to be more likely to work. And we see that in this study as well. Now, it didn't mean that you couldn't benefit if your PD-L1 was lower, but the benefit was greatest if it was high. So right now, the FDA approval and the way it can be used in clinic is anyone stage 1B and higher with any PD-L1 score. But when your doctor is deciding if they might recommend it, they might be thinking, well, where do you fall on these sort of spectrums in terms of the extent of your disease, your PD-L1 numbers, your other health conditions that might impact risk of immunotherapy? And that may help them make a more personalized recommendation. So speaking of risk, so these are side effects in the CheckMate 816 study. So these are the most common side effects seen in at least 15% of people. And these are really standard chemotherapy side effects, what we see on chemo. Risk of nausea, other GI side effects like low appetite, low blood counts, things like that. These are often manageable medications, but they're things we watch for, and they do happen in both arms. Maybe more importantly, when you add immunotherapy, you think about some of these immunotherapy-related side effects. These are related to immune system activation causing autoimmune disease instead of just the anti-cancer effect that we want. The most common of these are things like rash or some hormone abnormalities, but there are a few that are kind of important when you're thinking pre-surgery, particularly the one box there, which is risk of pneumonitis. So, and that can cause lung inflammation, which can interfere with safety of surgery. So this is something that's tracked closely. These were all consistent with what we usually see in patients getting immunotherapy. There wasn't any extra risk seen. And certainly, as I said before, as we showed before, patients went on to surgery still at actually a higher rate despite this treatment. So it seemed to be offering benefit, and these side effects, while present, were not preventing patients from, on average, getting the treatment that they aim to do with surgery. But depending on your health, for example, if you have autoimmune disease or other medical conditions, these risks might be different. So it's something your doctor would also consider when giving advice about using this regimen preoperatively. So I had a CheckMate 816. That's the top line here. This is an example of a lot of other perioperative immunotherapy regimens that are either in clinical trials right now or have some published data. And the blue boxes are immunotherapy components. The orange boxes are chemotherapy components. You can see surgery there in the middle. So pre-op therapies on the left, post-op therapies on the right. And these vary in whether they do all pre-op therapy, all post-op therapy, or a combination of both. And they vary in whether chemo is required or where it's used. So we're still waiting to understand, is all pre-op going to be better? Is all post-op going to be better? Is it better to do both? And that's something we're all going to be watching very closely as we get more and more data from these different clinical trial strategies. So what about driver mutation positive lung cancer? You might have a driver mutation or know someone who has a driver mutation. This is a very different subset of lung cancer. These are things like EGFR positive, ALK positive, ROS1 positive lung cancer. These often strike different patient populations than average lung cancer. Patients are more likely to be younger, more likely not to have a significant history of tobacco use, for example. And these tumors interact differently with the immune system. Now, in the metastatic setting, so more advanced disease, we know that having these sorts of mutations really seems to reduce the chance of tumor response to immunotherapy alone for lung cancer. That's what this graph here shows. It's from what we call retrospective data. So they looked at all their patients that were treated and looked back at how people did. And they showed that for people who had some of these classic sort of less associated with tobacco use mutations, highlighted the orange bar there, they were most likely to have disease progression as their best response to treatment. So really no response at all, and that's the dark blue lines. And because of this and other similar data, a number of these different clinical trials looking at using immunotherapy don't allow people who have some of the most common mutations like EGFR and ALK from participation, because they're worried that that treatment won't be effective. In my own practice, I'll usually avoid these sort of treatments for some of these classic mutations like EGFR and ALK, and instead really focus on getting these patients access to EGFR, ALK target, or other targeted agents and other types of clinical trials. So I think it has two different tracks. You're either on the immunotherapy track or you're on the targeted therapy track. So it remains to see, what are some of the unanswered questions here? And some of these that come to mind for me are, is immunotherapy best given before surgery, after surgery, or at both phases of treatment? We have trials exploring all of these different options. Should patients with low PD-L1 levels or earlier stage disease, like stage 1 or stage 2 disease, still be treated with this regimen? They didn't benefit as much when you look at those little subgroups, but still have potential to benefit. What if you get your cancer out and it looks like there wasn't a really strong anti-cancer effect? There's still a large fraction of the tumor that appears to be alive after your preoperative treatment. How best do we change that risk? Is there anything that can be done to maybe treat postoperatively to try to reduce people's risk of relapse in the future? And lastly, of course, how do you best manage cancers with all these other driver mutations, especially like ROS1, RET, HER2, which are a little less common and we have less data? Should these patients get this sort of regimen? Should they get targeted therapy regimens? And how do we decide? And so my takeaway points here, this is again, brand new really in the last 6 months for people with lung cancer, that the use of preoperative chemoimmunotherapy reduces the risk of cancer relapse after surgery for lung cancer. And that benefit is greatest if you've got stage 3 disease or high levels of PD-L1 expression on the tumor.